Hello, and thanks for tuning in to this quick online class. I am recording this on March 17th. I want to say first and foremost that I am so sorry that you are navigating this part of your pregnancy journey in a time of such confusion, fear, and disarray. It's certainly less than optimal. I hope you find some guidance and support and some peace of mind through this video. My name is Flynn, and I'm a birth and postpartum doula of over a decade, a doula trainer, parent educator, researcher, author, and I have a good deal of midwifery training under my belt. Things are changing really rapidly around the coronavirus, and I want to say clearly that hospital policies, insurance considerations, and individual abilities of midwifery practices are so variable at the moment that I have to say what I'm going to say at least somewhat general. I am more than available in the coming weeks to touch base with you individually and help direct you to more specific resources as best I can. So please don't hesitate to reach out to me or some doulas and midwives in your area. We are here for you in this time. Okay, so if you're watching this, you're wondering what your options are around navigating hospital births in this time or considering switching to midwifery or home birth care. I want to run down a few general points about what midwifery care looks like, as well as touch base on the various options that you might have for a safe birth around this pandemic. First off, it is worth looking at the information that the CDC and World Health Organization have put out around the COVID virus and your safety around pregnancy and the safety of your infant in this time. Generally speaking, as far as we know, there is not an increased risk of infection or mortality chances, morbidity, for infants or for pregnant folks. So not talking about necessarily risk mitigation in that context. However, we're talking a bit about, and your concerns around accessing medical care is around transmission rates, I'm sure. And so that's kind of where I'm focusing this conversation to support those questions. All right, so let's start with a very general rundown of midwifery care. Midwives are primary care providers, which means that they can care for you and your baby all through pregnancy, birth, and postpartum without the need to have other oversight. So they don't have to necessarily work with an OB. Unless there is a need for surgical birth. So that's transfers for cesarean, vacuum, or forceps, and with some other high-risk factors. And I was thinking about going over the long list of risk factors here in one of the major textbooks for midwifery, Heart and Hands. But I think that's so variable based on what state you're in, your midwife's access to different equipment and so forth. And so I think on those conversations, you're going to need to touch base with individual midwives in this time. Doulas are different than midwives. They are non-clinical support persons. And ideally, you're working with a doula and a primary care provider team. So not just a doula, but we'll have some conversation about that a little bit later on. There are 3 different classifications of midwifery certification, which I will get into in more detail soon. But essentially, they have the same access or ability to care for you. The difference in normal circumstances is primarily in location and how they were trained. Midwives are able to do all the standard lab tests for you prenatally, come to birth with medication and equipment to assist you in the rare emergency situation, and can do full postpartum exams for you and baby. And in fact, they see you more often in postpartum than hospital care providers and sooner. So there's an increased safety in that component. Some midwives are able to bill some insurances for some services. And I'm sorry, that sounds like the vaguest, dumbest sentence, but that's how vague and dumb our insurance network is. Caseload midwives use less technology to care for their clients and practice strong patient-centered care. So they won't be moving in and out of your room or in and out of your home and seeing multiple clients at the same time in birth. Mostly there are some rare circumstances where they're managing multiple births at a time, but usually they'll call in a backup rather than go back and forth. And they don't utilize nurses to monitor you and your baby once you're in active labor. They're there with you till several hours after baby is born. And this continuity of care is really one of the biggest reasons why out of hospital midwifery care is so safe is because of this constant monitoring of you and being there physically and mentally present at your birth. Midwives sometimes utilize doulas to help communicate client needs and to help assess when it's best for them to arrive to assist you. And this can be incredibly useful since midwife's role is crucial in the hours just before and just after a baby is born, and you'll want them to be well rested. So doula can really help with that dynamic. In all but more extreme cases of access, or if your birth is particularly rapid, you will have 2 midwives with you once you're in active labor. This helps ensure that there is always a trained primary care provider available for you and for your baby, and that helps with an extra set of skilled eyes and hands at all times. There are risk factors which make it so that home birth with midwifery care is less than optimal. Those risk factors are likely very different than the ones you might have heard from your hospital-based care provider, or just with how colloquial it is. Most people say, I had an emergency cesarean, I had an emergency this, that, or the other thing. And the truth is, when we look at the medical stats, most of what's occurring is not an actual emergency. It was, even if necessary, it wasn't an emergency, and there would have been time for you to transfer, and midwives are skilled enough to know when to make those transfer calls. So some of the things that aren't actually high risk factors, for example, advanced maternal age, aka geriatric pregnancy, which, yes, that is actually what it's called in medical records, which just means that you're pregnant after you have turned 35. God forbid. It's not a high-risk factor, and that alone will not risk you out of having midwifery-supported home birth. Neither necessarily is gestational diabetes if it's well-monitored and diet-controlled. And some midwives have different feelings of when they would transfer out for that. So if you are someone who's seeking out-of-hospital support in this time and you have gestational diabetes, it will be an individual factor. And there's other things that are considered high risk in a hospital setting like that may be negotiated on an individual basis depending on what midwife you work with and what's actually going on in your individual situation. So that's worth noting. Your ability to have midwifery care with certain risk factors is also partly up to state licensure rules. So that's really important too. Generally speaking, birth is not a one-size-fits-all scenario, and the strongest case for the safety of midwifery-led care is that midwives are trained to see the patient as an individual, taking in a variety of data points over something that is more like an assembly line system that we have in most hospitals in the U.S. So you'll probably notice if you start interviewing other midwives, if you're even contemplating care outside of the hospital, I think you'll notice a difference in the way they talk about supporting you right from the jump. All right, so now let's really briefly look at the different types of midwives and doulas. I'm going to be posting more about this on my blog soon, just as soon, hopefully, as I stop having to clean up my dog's diarrhea, because of course this is the best time for my dog to anxiously make himself sick. But I will keep posting stuff online, be doing other videos and letters and blog posts and posts on social media about these different differentiations and some updates on this general information too. So stay posted. But for now, all right, 3 different types of midwives. First is a CPM or LM, that stands for Certified Professional Midwife or a licensed midwife. The distinction between the two of those is most often one of how the state recognizes these midwives and not necessarily what their education or experience is. These are midwives who specialize in home birth or birth center birth. They have gone through the required trainings, which often takes somewhere between 5 and 8 years to complete for most midwives. And they've passed the National Midwifery exam and currently maintain their state's licensure or certification requirements. They are experts in normal birthing, prenatal care, postpartum care for you and baby, and often they hold advanced degrees and complementary specialties. It is totally appropriate to ask any midwife you interview what their education and training background has been, if they're licensed, how they practice, what their practice looks like, who is their backup, how many clients they're taking right now, and so on and so forth. The next type of midwife is a certified nurse midwife. ACOG and the U.S. cultural conversations around midwives has largely been more accepting of this category of midwives, but without much evidentiary backing, they just decided to accept nurses and not direct entry midwives. Midwives don't necessarily need to be nurses. There is no direct benefit to having done rotations in geriatrics and cardiology and all of that for becoming a qualified midwife. They are nurses first, and then they do a master's in midwifery. So it's just a difference in training, but they're getting largely the same midwifery knowledge and education as they would if they weren't nurses. CPMs are just as easily able to do lab tests, insert IVs, do sutures, and any of the more recognizably medical methods of care as certified nurse midwives, too. So note on that. In this country, however, only CNMs are given privileges to be primary care providers in hospital settings. And in some states, they are the only providers who can operate independent birth centers. They can also work at home, and many finish their training in the medical model and then work exclusively outside of the hospital. CNMs take the same national midwifery exam as CPMs, and make sure to ask your potential midwife what their training is around that if they're nurse midwives as well. The less common third type of midwife is a lay midwife. These midwives have carried on the age-old tradition of apprenticeship. They often work within small and often very religious communities and may have not maybe taken the national midwifery exam. That varies a lot. Though the standardization of this sort of care is not apparent always, there are plenty of incredibly skilled lay midwives who have attended large numbers of births in their time as midwife. The major difference there, and this is important to note, may be in their ability to access medical equipment depending on the licensure requirements in the states where they practice. And it's totally okay to ask a midwife who is a lay midwife or direct entry midwife about their training and what supplies they're able to gather in that state with the stratification of midwives legally in any state. But really, overall, the letters after someone's name matters a lot less than how you're able to communicate with them, how well you feel like they're able to support you individually, and just in consideration of your overall needs and health status, and how a midwife, regardless of what their training was, is able to support you through that. An important side note on doulas. Also, there are many different types of doulas. There's many different paths to becoming a doula, many different training and certification programs and requirements and education models. They are not really primary care providers, and they're not going to be able to have access to medical equipment unless they are also midwives. So in the rare case of an emergency, a doula is not going to have an oxygen tank, misoprostol for hemorrhage or Pitocin for hemorrhage, and those sort of things that really help make the majority of home births safe. But the levels of comfort around a doula assisting what's called a free birth, or a birth that is not attended by a primary care provider, will vary, and it's strongly advised against by the vast majority of doula training programs. However, these are strange times, and the decisions around the health and safety of you and how we're interacting in the medical system in general is being challenged constantly. And I mean this to be very broad, not just about doulas and not just about free birth and not just about home birth in general, but it's ultimately up to you to decide what sort of care you wish to have in your birth, and that is always the case. And just to be very clear, the U.S. has some abysmal and embarrassing birth statistics, and that's largely in hospital settings. And this shift to out-of-hospital births is long overdue, and other countries are way ahead of us here. But still, you shouldn't be made to feel like you're taking on extra risk with whatever decision you make. So not feeling like you're putting yourself at higher risk for going to the hospital with this pandemic, and not necessarily creating fear-based decisions around your ability, access, or desire to give birth at home with whatever sort of care provider that is available to you. And issues around access points like the finances, insurance decision, judgment from your family and friends, considerations around fear and intimidation, all that needs to be pushed aside as much as possible. Have your baby safely now and deal with whatever structural issues later. I cannot emphasize that enough. All right, so let's look at your options. First is if you're already seeing hospital-based standard obstetrical care, you could add hiring a doula to that. It's a great option even when there's not a pandemic, and it's even more essential when there's all of these huge and ever-shifting components of pregnancy care. And also when the medical system is so particularly taxed right now, having a non-clinical support person can take a huge burden off of you and also off the medical establishment. Doula can be your eyes and ears around situations occurring at local hospitals, so we're all in communication with each other around that all the time. So what hospitals are allowing X number of support persons, what hospitals are on shutdown, what hospitals are taking overflow, things like that. And also helping you navigate the standard care you need in pregnancy and postpartum. So be that from OBs, nurse practitioners, clinics, midwives, etc. And perhaps the most critical point right now with the pandemic is that doulas are trained primarily to help you stay at home as long as possible in labor. So it's the less time that you're in or around a hospital right now, and providers who are working in hospitals and have increased exposure is all the better. They can also take a huge stress load off your partner, who is likely also experiencing some heightened levels of stress right now. And issues around accessing doulas, it might be last minute, you might not have budgeted for that. We're doing all sorts of adjusted care. We're doing a ton of virtual consults. We're assisting folks virtually in labor settings. We're working on sliding scale. We're taking donations. We're doing all sorts of things to help people have more access to us in the coming months. Okay, second option. Keeping with your plan to go to the hospital with or without a doula, but seeking midwifery care for prenatal and postpartum check-ins. So, like I mentioned before, out-of-hospital midwives and independent birth centers are able to provide all of these services, minus some optional clinical assessments like ultrasounds and amniocentesis. And yes, ultrasounds, though often advisable, are optional. Many of your routine exams in hospital settings are also optional, though they are rarely presented as being optional. Home birth and birth center midwives can walk you through the hows, whys, and whens these tests, what they are and when to perform them, and can help emphasize that it's at your discretion to utilize any of these. I've recently had some clients ask about hospitals not accepting testing from out-of-network providers like home birth midwives. It's a really important point because it's probably a huge consideration for a lot of folks. And I want to, with full clarity, break this down for you and really hope you have this broader theme sink in for you right now. The testing that is done in pregnancy and postpartum is and should primarily be to gain understanding of your health and that of your fetus or your baby. It's not to check off boxes. It's not about hospital policy. And if you're disrupting their system and their flow at this time, with all love and honesty, tough shit. The tests are so you, as the primary care provider of your own body and your own baby, can make decisions around your care, and for the care staff to follow that, starting from you, not the other way around. That it's been hierarchical, top-down, and forced into weird systems so that insurance companies can charge effectively is not for your own safety so much as supporting this system that's so tragically flawed already. If there's one thing this pandemic is highlighting, is that our medical system itself is diseased and flawed. So please make decisions around your care, how you access this information, what information you need to know, and how to utilize that information, meaning the information you're collecting from tests, at your own discretion. Our entire medical system is going to need a period of rest and readjustment, and obstetrical care is not some weird exception to this situation. I wish I could interpretive dance for you or sing or something how strongly I feel about this. Each of my bones is wanting you to know that this mode of thinking should be, how can I safely access the care that I need, and not how do I make my health provider and insurance company acknowledge this care. So that is to say, if you seek any care outside of the hospital system, get the care that you need and deal with the structural issues later. And there's going to be lots of midwives and doulas around to help you figure that system out. So your third option then is to switch entirely to home birth midwives. So no worry about the back end of that communication. You're just signing on to work with home birth or birth center midwives. And it's for all the reasons I've stated already, plus the likely total avoidance of the hospital in a time of viral pandemic, which guess where the sickest people are? They're at the hospital. So this is not even just for issues around transmission, but also in consideration of how burdened the staff at hospital systems themselves are at this time. So it's flattening the curve, it's social distancing, it's all of those considerations rolled into one. And I'm sorry to report to you that the standard hospital care for pregnant folks in this country is already shocking. And I'd like to point you towards a research paper that the American Journal of Obstetrics and Gynecology published in 2011. It's called The Scientific Evidence Underlying the American College of Obstetricians and Gynecologists Practice Bulletins. So if you type that into Google, you can find the full article there. And that outlines how 2/3 of standard obstetrical protocol is not based in high-level research to begin with, but rather opinion. So there's that already in non-pandemic times to consider when thinking about seeking out-of-hospital care. Now, add a viral pandemic and loads of people who are unwell going to the hospital and adding stress to the system, and it's really, we're getting a lot of mixed reports on how that's affecting L&D wards. Some not much at all, some quite a lot. And American care providers aren't necessarily prone to listening to the World Health Organization, which suggests that there should be no drastic changes in care at this time for pregnant folks or for infants, including no increased risk or chances of cesarean birth. But I'm not going to get into speculation about it. I just already see quite a lot of not listening to standard recommendations in general on hospital floors for so many economic, political, cultural reasons already that I can't imagine that this time is some sort of exception. Also, right now, hospitals are taking some very extreme measures and limiting who can be with you in labor. So that's sometimes not even allowing partners or support persons. Or if you do have a partner or a support person like a doula or another family member at your birth, nobody's allowed to leave and return, which might be really challenging to you if you have older children as well. If you need to caretake for somebody else in your family, so on and so forth, there can't be kind of the normal in and out and tag team experiences that often happens when folks have multiple support persons. So it's worth considering. So it may be that the safest place for you right now, if you are experiencing a very healthy and low-risk pregnancy, is at home. Give birth at home with a midwife, some skilled midwives. There's still a chance that you have to transfer to the hospital with a home birth, either during birth or just after. But those numbers tend to hover somewhere around 10 or 15% of home births transfer. So it's highly likely that you won't be needing to access a hospital or engage in the hospitals right now if you choose to birth at home. All right, so those are the options for birth and prenatal care. Now, if you've already given birth, you may be finding it hard to seek follow-up care with everything that's shifting. Or you might just be wanting to limit your exposure to hospital-based care when you are already recovering, your body already feels taxed and exhausted, and you're caring for an infant and maybe don't want to expose your infant to these areas of increased transmission rates. So midwives can do postpartum home visits at any point in your fourth trimester. Like I mentioned before, standard with home birth practices and birth center practices are that midwives are seeing you more frequently and sooner in postpartum than that ridiculously way too far out 6-week appointment that you get with hospital-based care. And there's loads of midwives who are doing just one-off follow-up visits. So you can ask a midwife to come and just do one of the standard check-ins for you and for baby in this time. You might also want to consider seeing a lactation consultant who does home visits in this time. They can help with breast or chest feeding, bottle feeding, weigh baby, see how baby's doing generally, those sorts of things. And even a postpartum doula who can either do, we're trying to limit how often we're doing in-home visits because lactation consultants are clinical and they can do test for weight and things like that. Midwives can do clinical exams. So there's some reason to see folks in person. Postpartum doulas can do a lot of their care virtually, and it might be worth talking to someone even just for an hour or two as a follow-up appointment if you feel like you want to avoid traveling to medical centers or group visits or things like that in postpartum. Also, really importantly, if you are formula feeding and you're having issues accessing formula, which has been an issue for folks right now, please, please, please reach out to a birth worker. We're in constant communication with one another about this issue, and we will help you access formula. It's very important, and we're definitely here and aware. How this will all work in terms of payment will vary enormously. Birth workers, we're all collectivizing rapidly to try and gather information on who's taking volunteer clients, sliding scale, pay later plans, donations, who's doing stuff on an hourly rate, who provides things that are covered by insurance, what midwives can prescribe things, so for STI treatments and birth control and things like that. If you work for a major company, right now I'd suggest strongly that you start contacting your HR department about getting reimbursement for all these adjusted services. Like, a major tech company has money to spare to help you with this. And also I'd call your insurance provider regularly. So a lot of times with all of this being covered, trust me, it's about getting the right person on the phone. And if nothing else, you can get some info on what paperwork you'd need to increase your chances of coverage for doula or midwifery care, especially for lab tests. So, midwives can then know what lab to send the test to, which will increase your chances of getting that covered by insurance. And, all of those things can help you potentially not have to pay out of pocket for all of this. I can say with a deep level of confidence that there is a lot of behind-the-scenes work going on amongst our birth community. And we're really trying to support pregnant folks and new parents in this really challenging time. And just a bit of a final note, I think it's worth sharing that home birth and birth center birth is safe for the vast majority of people. Midwifery care is the standard in every country that has the best maternal and infant health outcomes around the globe. The U.S. really stands in stark contrast to most other industrialized nations in our overuse of technology and our underuse of midwives, and how little time that hospital-based providers even spend with patients around the whole childbearing year. It's awful when you look at the comparisons of the U.S. and other countries, and it's embarrassing, and it's costing us a ton of money to boot. But having said all that, I don't take a strong amount of glee in how awful the situation is and how it perhaps is helping people in this country really understand the importance of utilizing ancient and safe practices in the childbearing year. But this is a calling that's gone unheard for too long, and this might be the thing that wakes some people up. That's just kind of a reality of what we're seeing on the ground, honestly, and what might have brought you to even accessing this video. So I want to acknowledge that. In conclusion, if you've been on the fence about out-of-hospital birth at any time prior to the outbreak of COVID, I really hope that you'll consider switching care and understand the benefits of switching care and how accessible it likely is for you, both for your own safety and for the way that it can protect all of us by keeping more of us outside of the hospital system. I'm in contact constantly with a number of L&D nurses, and they've been seeing how their supplies have become limited, how their rates of stress in the management of care has increased tremendously, and how much they see shifting in the hospitals where they work and the units that they're on in the past few weeks. So it's a real thing. This is serious, and all that's really happening. So if you feel like home birth can be a safe option for you, there are definitely ways of accessing care, and I'm happy to help you as much as I can. I'm located in the Bay Area in Oakland, so I can offer specific support here with actual names of midwives and birth centers and up-to-date information on the hospitals and what doulas are doing. But I'm also happy if you're outside of the Bay Area to help you access more broad-reaching information on how to find midwives who practice in your area as well. So, thank you for tuning in, and I wish you all the best, and just remember to wash your hands. All right, bye.